I'd like to welcome everybody to today's webinar, which is part of our Improving Ohio's Health series. Today we're going to talk about an updated encoding and billing. It's a proposed rule that addresses chronic care management. This is it was buried in the physician fee-for-service rule. We will do the Q&A at the very end of the presentation. You can enter your questions at any time into the questions feature of GoToWebinar. Then we will run through all the Q&A at the very end. With that, I will turn it over to Ms. Cathy Costello.
Thanks, Scott, so much. Welcome, everybody. Glad you could join us. This has been a really interesting series of webinars and process over the past year and a half with ODH. What we're going to cover today is restate and show you how the emphasis on chronic care management is shifting and how chronic care management fits into some of the new healthcare reforms, and specifically what the changes are that are required by Medicare going forward in 2017 to be involved in chronic care management programs. This webinar and the series is all part of the Ohio Department of Health's Improving Ohio's Health plan or grant. And there are two big grants that this is part of. The first one is to more effectively manage chronic conditions and reduce their prevalence in the population. And CDC has funded this grant originally in 2013, and the state of Ohio received additional funding in 2014 to support this effort to control diabetes and hypertension in Ohio. Both grants are designed to show how health information technology can improve the performance for chronic disease management. The second grant, the first grant is statewide. The second grant is centered more on local efforts to control prediabetes screening or to support prediabetes screening and other strategies to improve obesity, diabetes, heart disease, and stroke in selected communities, so these initiatives then can be taken statewide. And these are what we've been working with Ohio Department of Health for the past year and a half on, and in specific counties like Athens, Lorain, Montgomery, Richland, Summit, and Washington. But as I mentioned before, whole elements of the Improving Ohio Health program is designed for this statewide implementation. So let's dig into today's webinar, which has to do with the coding and the whole approach to chronic care management that CMS has established over the past 2 years, and then looking forward to what is going to occur over the next year. There are several terms that I just want to point out before we get into the webinar further, because you'll find me using acronyms. You can tell I've been working with CMS too long because they're so in love with acronyms that I find we start using the same shortcuts. So chronic care management is the first one, big one. CCM, you'll hear this used now all the time with CMS programs, and I'll show that to you as we get further into the webinar, how this feeds into some of their other initiatives. TCM is the partner program to chronic care management. TCM is transitional care management, and the transitional care management goes to the issue of managing patients that are being released primarily from the hospital setting or the ED is what the coding is used for, what the program is designed to address. So chronic care management is the ongoing care of patients who have 2 or more chronic conditions. Transitional care management is immediate follow-up after release from the hospital. 2 of the groups we're especially speaking to are the FQHCs, the Federally Qualified Health Centers, and RHC, the Rural Health Centers, and that is because they now are included in the ability or the groups that can bill for these services. And the very last thing that I want to point out is the billing side that we're going to be talking about. First of all, E&M services, evaluation and management services, and that goes to the coding for what is done in the office setting. And then the three new areas in addressing changing in payment and billing, and that is MIPS, Merit-Based Incentive Payment System. You'll hear a lot about this over the next few months as those rules become final. And the companion to MIPS is APMs, which is the alternative payment model. So this really includes many different payment models that are other than fee-for-service. And the last thing I'd like to point out, because I will talk about where it comes in when you are figuring out how to handle chronic care management in light of all this new payment reform and working with various payers. But you will see in some both public and private payer areas going forward over the next couple of years that your practice may be moving into a model in which you are, rather than being paid strictly fee-for-service, you either get paid alternatively a per member per month, or in addition to fee-for-service, you get paid a per member per month fee. And the per member per month fee is usually an add-on that can run from anything from a few dollars up until some of the programs are showing $30 per member per month to basically manage the care of patients, and especially those with chronic conditions. So this all flows together, and sometimes I don't know if we're very good or very lucky as a state and as a country in this area. But the work that ODH has put forth in getting this implementing or supporting Ohio's health, moving to new strategies on education, really feeds in exactly in the same time frame that we see these new payment mechanisms coming about. So who would have thought that we are actually able to educate people before the payment reform comes in, so you can hit the ground running if your practice decides to participate in some of these new payment options. So let's go back to the basics here. I know we had done another webinar on chronic care management, but I think it's worthwhile reviewing because you will see a lot of changes between what CMS was having practices do in 2016 and what you'll be looking at in 2017. So the chronic care management model itself is any program that is designed to provide additional coordinated health and social services to patients with chronic conditions. So that is the key there, additional coordinated health and social services. So above and beyond what you do for your patient in the office while they're in a face-to-face visit, what else needs to be done to provide patient-centered care that is going to improve that patient's condition? The purpose of a chronic care management is to treat the patient holistically. You are not just looking at an acute symptom. Patient comes in with a sore throat. Thank you very much. Here's antibiotics if it's strep throat, and we'll see you next time that you're sick. The idea, rather, is to say, as the patient comes in the door, you may be seeing them for an acute condition, but recognizing that there may be many, many other factors that need to be addressed. Is this patient diabetic? Does this patient have congestive heart failure? So you're looking at the broader picture at the same time that you're treating a specific condition. And as part of that, you may need, and in many instances you will need, to have someone who manages assistance to that patient when they're not in the office, when there's not a face-to-face going on. We all know how much care and coordination is required for your chronic condition patients, where it requires assistance for them either with other practices or with social service agencies, sometimes as basic as getting them transportation or helping them find transportation to get them to the office if they need to be seen. So you're looking at, as I said, the holistic approach to patient care. The structure in a chronic care management program, as we're talking about for Medicare, because there can be many different chronic care management programs, but for Medicare, the chronic care management programs are almost exclusively managed by primary care practices. With few exceptions, you might see specialty groups like cardiologists involved in this, but for the most part, it is a primary care program. And the reimbursement, and we'll talk about all the various places where chronic care management has reimbursement, but in the specific coding that CMS started in 2015 and 2016, you are looking at managing patients outside of the office setting to raise the quality of the care that you can provide for them. So this is an extremely important area. It's, as I said, you know, we've all been running at light speed to get caught up and to stay up with all the changes going on. But the reality is it's all happening simultaneously, and everybody has come. It's like we've all been, the light bulb's gone off above our head, and all of us realize at the same time that this is really a good idea. It's just how do we go about implementing it? And the National Council on Aging probably said it the best. Addressing chronic disease requires new strategies to delay health deterioration, improve function, and address the problems that people confront in their day-to-day lives. So we're looking at this, and what you'll see in the proposed regs for 2015 or 2017 is just that, a new approach that CMS has taken the ball and run with it, trying to address problems that were pointed out or became evident this year as they tried to implement these CCM programs at a higher level with more practices. So in order to talk about the changes, let's talk about how the program is currently structured. So the program is currently structured, as I said, pertains primarily to primary care practices, but I just have to make sure that you are aware, see that little box on the right-hand side, that effective this year, rural health centers and FQHCs also could bill for chronic care management services. So this is a change because these two groups have a different billing structure than a regular independent practice setting. So I just want to make sure that you all are aware that you too can bill for this. A very important change when you're doing your transitional work in transforming your practice. You want to build this into your plans. So in the current setting, what CMS is having practices do this year, and I know that we've had a few that have been able to successfully implement this. It takes a lot of planning. But in a chronic care management program, you have patients who have identified at least two chronic conditions, but the key here is that it does not have to be off of a checklist of chronic conditions. It's whatever the treating provider identifies and puts documents in the record. And in the case of what we are talking about, and I think the most common areas where you see the CCM programs work successfully, the practice takes one or two very high priority items and concentrates on those as their first level of conditions. And so this would be diabetes and heart failure or hypertension. And you'll find that most practices begin that as they identify what their high priority patients' needs are. So if you have patients with diabetes or hypertension, what you want to do in order to get them into the program is to document a second chronic condition, because believe me, it is not difficult. CMS has pointed out things as as simple as osteoporosis. It's simple not to the patient, but as I'm saying, it's a complex chronic condition. Osteoporosis, it can be arthritis, it can be as complex as behavioral health needs. I mean, there are all kinds of things. So don't limit your thinking. CMS has made clear many times it can be any two chronic conditions can trigger the use of this program to support the patients. In 2016, in order to initiate chronic care management services, you had to have a comprehensive visit. It had to be level 4 or 5, annual wellness visit, initial preventive physical exam. Required written patient consent to participate in the program. Structured data had to be available in an EHR system with a care plan developed. There had to be 24/7 access to the record in the care plan, and there had to be continuity of care by the practitioner or member of the team. So basically, someone quarterbacked the care of this patient, whether they were providing it or not. So the patient was receiving care by individuals who were familiar with their needs. And then there needed to be an assessment of needs, development of a care plan, and then electronic transitions of care or referral in coordination with community service providers. If you think this sounds a lot like PCMH, you are absolutely correct. You know, that's one of the things as we've been working with more and more programs going forward, there are such common elements, which is why I said no matter what you're going to be doing for reimbursement over the next few years, you absolutely want to build this in because the elements show up time and time again for chronic care management, no matter what the reimbursement model is. So why is CMS making changes when it was only in 2015 that they began transitional care management, paying practices increased funding to take care of patients coming out of the hospital, and then in 2016 they added the chronic care management program. So we're less than a year into the coding for this CCM program. And the reason why is it has not been well adopted yet. Out of 55 million Medicare beneficiaries in 2015, only 275,000 patients were enrolled in CCM. So it's really, it's been less than 1%, shall we say. It's been an underwhelming response to an overwhelming problem. Why was the change necessary? What was going on? Well, they did a survey at the end of 2015 to say, what's the problem? And so the National Chronic Care Management Survey showed that only 26%, so only a quarter of all the responding organizations had launched a chronic care management program. And when they asked why, there were 3 reasons that came through time and time again. The first one was that many practices and organizations thought that it was insufficient reimbursement for the time required. And we'll look at the time requirement here in a minute. But let's just say they felt that they were not getting reimbursed for the amount of time that was actually required to manage these patients with chronic conditions. Second was the lack of awareness. CMS rolled out this program without a lot of advance fanfare, although the American Academy of Family Physicians, AAFP, I thought did a really good job alerting their membership to participating in it. I don't think there was an enormous amount of publicity around this, and part of that was uncertainty about how the various elements would be implemented. So there's been lack of awareness, and then the third thing is compliance concerns. And the interesting thing, as we looked at it from a technical standpoint, I know Scott and I have commented on this several times, is that the original elements of chronic care management very, very closely mimicked stage 2 meaningful use and interoperability. And it was unusual because there are really very few other programs that CMS is paying for that has that as a basic requirement other than for meaningful use. So one of the things, the question of timing was a big one. And so researchers found that the median time spent for providing chronic care management services was really 35 minutes per patient per month, rather than the 20 minutes that is required under CCM. And so, and the other thing, the reason they were saying reimbursement was inadequate is that most programs that set up, it's not a requirement of the program, but you'll find, at least in the programs we've worked with, that usually it is a registered nurse who is providing the care. And so because it's a nurse as opposed to an administrative staff member, which it could be under the billing regs, I think practices feel the nurse can better assess what the patient's needs are and what needs to be done immediately if there's a problem. And so this is a more expensive addition to the cost of a chronic care management program. So this is why CMS was thinking, gosh, maybe we need to do something differently. So CMS responded in these regs, and Lord knows they put out enough regulations this year, but they had a very long section about what their thinking was. It's almost like a stream of consciousness around chronic care management, but they did probably at least 30 pages on chronic care management and what their thinking was, what they were trying to accomplish, and then what they were going to do moving ahead. And they want to establish, because this is a new program, they know it's not perfect. And so they're trying to establish a program that is more responsive to the patient's needs, but also to the practitioner's needs. Because as you know, in 2017, which is less than half a year away, all these new payment reform models are going to take effect, at least for Medicare patients. And so they were trying to fit what the requirements were into a format that was going to be supportive of these new payment reform models. And so one of the things that we saw when we were looking at the regulations in these areas is that the chronic care management program itself is actually specifically called out as an area of clinical practice improvement, which is activities, which is one of the areas that the physician practices will be judged on going forward. They're saying, have you improved the care in your practice or your care as a practitioner yourself? And so there was maybe 50 different things that you could be doing to improve your clinical practice, and one of them specifically is chronic care management and transitional care management. So there is a recognition by CMS. They're trying to dovetail these things and to make use of good programs in other places to support increased reimbursement and say, yes, practice, you are doing a good job taking care of your patients. Then the other reason that, clearly a reason that they were pushing to a newer updated model is the low adoption rate. I think they were really shocked that more practices did not take advantage of billing for this chronic care management. But they, I think, also recognized that the program requirements were very structured. And as I said, CCM was, it may be the only program I can think of other than meaningful use that makes use of the meaningful use requirements and actually builds them in as a requirement to participate. So in CCM, you saw a lot of things that required use of electronic health records, that you had to do a electronic transition of care when you send information to another practice. I mean, there were a lot of things that they were looking for that were actually, the underpinning was meaningful use. And they were like, maybe practices aren't quite ready to do this. We all know the interoperability questions remain. Even in Ohio, where we're much further ahead than most states, it's not like every practice is connected to the HIE and it knows how to transmit those documents electronically. So CMS is thinking, what can we do to improve this? And then the last reason that they went into this changed mode on CCM is that they really wanted to encourage practices to spend additional time with patients who have chronic conditions. How have the payers responded to this new area of coding and this new approach to having practices basically take ownership for their patients? Because as we all know, the payers themselves had stepped in a lot of cases to take over the role of chronic care management for patients, especially as they come out of the hospital, and they might assign case managers. And so they were taking over the function of the primary care practice. And so as practices come back online on managing these chronic care patients, the payers are having to take a step back and assess how they're going to be working with practices that are doing this. Excuse me just a sec. A lot of payers are now recognizing some element of the chronic care management program. Most have started to pay for it. But what we found interesting as we surveyed the payers is that we found at least one that kind of cut out the practice totally in their work as payers to push chronic care management, and they have gone around the practice and they are working only with the patient and not with the practice on having the patient's care improved. So, I mean, just to give you an idea of what we're seeing out in the marketplace. But the good news is that for payers other than Medicare, who obviously has embraced this big time, more and more payers are recognizing it. It's just that they aren't consistent in their response yet. So that's one of the things over the next year or two we'll be watching to see if there's a more organized response. The one thing that I would say in understanding whether you can get paid for chronic care management, and this is a real big thing, especially as we move into 2017 with new payment models, and that is you need to understand what your business model is for the organization. How are you getting paid by various payers? So it may be that some payers will pay you for their chronic care management codes and others won't, depending on if they're already supplementing your reimbursement to have you get a per member per month fee for managing what they recognize is going to take a heavier lift to take care of patients who have chronic conditions. So you want to start, first of all, talk to your billing office, your administrative people, your CEO or top doc, and find out how the various payers are, what your contracts are in this area. So as you see more payers starting to pay a per member per month management fee, fewer of them, in fact, right now, I don't know any, if you're getting per member per month fee, where they're also going to pay for chronic care management. So that's one of the things you want to be aware of. And as the new CPC Plus payment mechanisms come in for Medicare and Medicaid, that's one of the things you want to be looking at. But be that as it may, on chronic care management, the fact of the matter is that all payers recognize the need to continue to monitor closely patients as they come out of the hospital. So whether or not they pay for CCM as a separate bill or coding, I do not know any that are not allowing you to bill increased billing for transitional care management for the patient who comes out of the hospital. So transitional care management is more of an episode. It's an acute one-time bill that is dropped right after the patient comes out of the hospital versus the chronic care management, which is going to go on for as long as there is a need. And that's why you're looking to see if you're also getting reimbursed elsewhere for that through per member per month. So let's look at the specific changes in the program. So you can look forward to what you're going to be needing to implement this. Between one year and the next, 2016 and 2017, you will still need to show that the patient has 2 chronic conditions. So document within your medical record what the 2 conditions are that you're relying on as to be part of a CCM program. The visit, which as we had covered before, had to be a level 4 or a level 5 kind of increased intensive patient encounter, or annual wellness visit, or initial preventive physical exam, now does not have to be initiated that way. It can be initiated through a routine office visit. So the patient comes in and they've got, as we said, they have the strep throat. Let's go back to that example. They have the strep throat. You treat the strep throat, but you're looking at their chart and you recognize that they're also diabetic, and you're thinking, you know, they could probably help them if they could be enrolled in this program. So you take the opportunity for this, what is an acute visit, to talk to them about getting into the chronic care management program. You get their consent, which no longer needs to be in writing. Big change there. We had developed consent forms that were based upon the chronic care management program, and although you still need to talk to the patient about it in that initial visit, you do not have to have written consent. You just need to document in the record the fact that the patient has given their consent. So it fits into better your normal office workflow, and what you would anticipate seeing with patients who have chronic conditions. You're going to see them for some other reason, and then it's getting them enrolled. Then the next requirement is structured data available in the EHR system still needs to be available in the electronic health record. So they want to see that demographics. They want to see the vitals in there. All that needs to be documented, same way as if you're working on meaningful use. Access to record and care plan 24/7. They still need to have 24/7 basis, but let's say, again, this is a change based upon the reality of how patients present to physicians. And in the middle of the night, if there's a problem, you know, it may be that that care plan is not immediately available, but you need to treat that patient. And so I think we've come full circle here, being raised in a family that my dad frequently received calls in the middle of the night. I can tell you that that's more the reality of the situation, that you want to address the patient's immediate needs. You want that information as far as care plan to be available, but it may not have to be available at 5 a.m. But you do need to be able to get that information during the office day for their care. And then continuity of care by practitioner, member of the team, yes, that still needs to occur. Assessment of needs and development of care plan. The care plan must be developed. The community engagement piece, so you've got your staff member, your RN, working with people out in the community that are going to support, whether it's a diabetes education program, whether it's a program on Meals for Wheels or Meals on Wheels, or it's behavioral health, whatever that is. You do not have to have a structured way of presenting that information within your electronic health record. You just need to document that those connections have been made, what you did with it. It can be attached. You know, I strongly encourage you, if you have a good electronic health record system that gives you a place to document it, to put it there, because it's easier for your benefit and for a treating provider's benefit, but it's not a requirement. If you keep a written record, if you keep a spreadsheet, you know, however that's done, CMS is not going to tell you how to do it. They're just going to tell you to document it. And then the last one is the interoperability piece, the electronic transitions of care. In the version as the CCM program was originally planned, and for those of you who are doing it right now, working under it, you were supposed to be doing an electronic transition of care or referral using direct email or using the community health record through the HIE. The reality is it's still the best way to do it as far as documentation, and that way you know that it's been received and stuff, but CMS is backing off that. They would not allow fax transmissions under the original program, and now they are allowing that. So if you have a partner in this process and they do not have the capability to receive an electronic email under direct, or you can't access it through the HIE, then you can fax that information over to them. Okay, this is kind of an expanded list of the same things that we just discussed. I would say very important thing for you all when you document in the record, and I know you've heard this from all of us on meaningful use for many years, but just make sure that when you're documenting in the record, you have the meds, med allergies, and problem list, because this is becoming so important as we get into these new payment mechanisms, because this is what pushes your quality metrics. And so please make sure that that all gets documented correctly. Then the care management plan, as we said, it doesn't have to be available in the middle of the night type of thing, but you do want to make sure that that care management plan gets shared both with the patient, does not have to be hard copy. And that was another funny thing about the way that CMS set up the program. And I don't think they meant it, but it was written in such a way that it looked like you had to hand the patient a copy of their care management plan, you know, on a piece of paper, whereas the reality is they're trying to push patients into using the patient portal. So this is now, they just kind of cleaned up that language, and you absolutely can post that into the portal for the patient's review or their need if they need to download it for somebody else, and that meets that requirement. And as I said, if you need to send it on to another person, you can fax it to them. Okay, so let's talk about the codes specifically as they're changing and what that might mean to how you're going to handle this from the billing and coding side. Okay, on the ones that we are currently working with, let's look at those again just so that you know which ones we're coding for. 99490 is the code that you use when you're billing those ancillary support non-face-to-face contacts that cover, you know, receipt of lab results, calling the patient about that, you know, calling another practice to get discuss the care with them, get you know, a visit arranged, you know, whatever it is, Meals on Wheels, whatever, that gets billed under the 99490. You have to show that you have billed at least 20 minutes per month by some clinical staff member. Or the other side of this, because we have seen smaller practices that can't afford to totally bill for themselves, you know, have a dedicated person doing this. You can use an outside group that will provide this chronic care management piece of the action for you, but then they will take a percent of the billing. So that is allowable under this. Originally they were going to just require it to be done by the office staff, but that is allowed under this. I'm going to go back to the new codes in a second. I'm just looking at the current ones. Now on this slide, the Transitional Care Management, TCM 99495 and 99496 are the ones that go to when the patient is discharged from the hospital and you're following up with them. And recognize that this is technically TCM, or Transitional Care Management, is not a subset of chronic care management. It's its own set of problems, own management of the patient post-discharge. But the reality is that as the patient comes in to be seen in that visit, which is anywhere from 7 to 14 days, depending on how intense their needs are and how complex the problem is, that patient, you can bill for that increased reimbursement there, but the reality is that frequently that visit post-discharge should set up to be your initial visit to get these people involved in chronic care management, because so many times as the patient gets discharged, and I know you're aware of this based upon our statistics that we've been gathering for the Department of Health over the past 2 years, we're looking at anywhere from 45% of patients being discharged from the hospital are diabetic around the state of Ohio. That's the average. And nearly 60% are hypertensive or have congestive heart failure or, COPD. Whatever it is, 60% represent hypertensive patients, 45% are diabetic. So as you're seeing your patients, setting up a mechanism to see your patients as they're discharged from the hospital, take the opportunity to get them engaged in the chronic care management program. The billing for transitional care management and chronic care management are mutually exclusive for the month in which they are seen post-discharge. So if you bring that patient in within 7 to 14 days and you bill for transitional care management, you will not start your billing for chronic care management until the following month. Now let's look at how CMS is changing this coding. They recognize in addressing these various issues that were brought up about lack of reimbursement, increased need for recognizing that it's going to take longer to work with these patients. Let's look halfway down this list. GPPP7 is the code that goes to the treating provider. So this is the G code that gets attached onto your coding for the E&M that addresses the additional work that provider is doing in setting up or following up on a chronic care management case. And it can be either face-to-face or non-face-to-face time. So let's say the patient, again, shows up for an acute condition and that a physician recognizes that there is more there than meets the eye, that they really need to be addressing a whole range of problems. And so what should have been a 10-minute visit at the longest, ends up being over an hour by the time that they regroup and assess the patient's needs and do this other behind-the-scenes work. And the visit itself may take a half an hour or more. So given that, you want to attach that G code for the additional time that the treating provider is using to work with this patient as they come into the chronic care management process. The other thing is could be also that the initiating visit is level 4, level 5, but the time just takes so long. It's congestive heart failure, and there's just so many issues. So whatever the reason is, look at using that G code to code for the additional time of your practitioner to work with the patient in that chronic care management situation. Then let's go back to the staff member or the nurse or whomever is the managing staff person for the chronic care management program. If what you're seeing is that person is spending all kinds of time on trying to manage that person's care during that month, and it's exceeded 60 minutes. They spent more than an hour on the phone or working with patient, trying to do stuff over the phone with them, whatever. If they have over 60 minutes designated to that patient's care as part of chronic care management, then you want to use the second code down, which is 99487. And that is, okay, so 99490 is the greater than 20 minutes per month. 99487 is an increased code where if you're spending more than 60 minutes a month in managing that patient's care, you want to replace that 99490 code with the 99487. Then let's just say it's like super tricky case, lots and lots of contacts, lots and lots of coordination, and for those of you who work with patients with chronic conditions, you know what I'm talking about. The 99489 allows for an additional 30 minutes to be billed beyond that 60 minutes. Then I just want to call out a few specific codes because this is one of the things we're seeing with chronic care management. CMS is really attempting to refine the program. They don't know how it's all going to fall into place. But two of the areas that they're trying to address with their new coding, and they're asking for comments about how it's going to work, is if you have one of your conditions is behavioral health condition, or if you have a patient with behavioral health needs, there's a whole line of new behavioral health codes that go to episodes of care around behavioral health. We aren't going to get into that because that's specific to behavioral health, but if you have behavioral health as one of the two chronic conditions for your patients in a chronic care management program, then if you look at the second to last code on this page, GPPX, is you're spending more than 20 minutes of clinical time or staff time a month managing that patient who has behavioral health condition. So this would be the G code that's added to that to specify that you're working with that patient who has a behavioral health condition. Then the other area that has become a bigger priority for CMS in this new coding is the work with patients with dementia. And we all know that can be an extremely both time-consuming and care-consuming area because you're coordinating not just with the patient but with the caregiver. There's a whole lot that goes into that. You need additional assessment of their ability, additional assessment of their medications. You know, there's a whole lot of things that go into working with people with dementia or cognitive impairment. And as these rules become final, we will go a little bit more into detail on that because there are some requirements about what you'd be doing, but I just want you to be aware that these two new lines of specified codes or specific codes for specific conditions are coming about now under chronic care management. One's behavioral health and the other one's people with cognitive impairment. Then the other two codes that allow for additional time when you're not face-to-face is 99358, which is non-face-to-face prolonged E&M services and after the first hour. And that's, again, for your treating provider or physician. And 99359 is if it takes even more than an hour for each additional 30 minutes, you would bill 99359. So in conclusion, a successful chronic care management program should treat the whole patient to improve their quality of life. It wouldn't it be nice if we could just delete the diabetes on everybody's health plan or health history. So with that, let's just say we'll be looking at this again as these rules become final. And that's one of the questions that have come in is the rules are not final yet. So they will be final in probably the next, let's see, we're in August now. I'm going to guess by late September we will have final on that and we can review how that became, you know, what the coding looks like as a final thing. We have one more webinar in this particular series and we'll start up again in the late fall, and this one is technology to support your patients with chronic care conditions. And with that, let me see what we have here. We have questions. Okay. Can these codes be used for case managers who are RNs? Absolutely, they can. Or are these codes for physicians? As I said, some of the coding, the G code and the additional 99589, 99590 are ones that can be used for the treating physician provider, but also if we have a nurse practitioner who is the treating provider, you use that for them. And, you know, the nurse is not limited in what role they can be playing here. They can be the treating provider. Say you're an FQHC, say you're any practice, where the nurse practitioner is part of the care management team and they're providing the top level of care, then you would be billing them out for this. And then you'd be billing the staff assistant time separately, whether or not the supervising or treating provider is an RN, is a physician. You still can also bill out the staff time to support this. Okay, this will be for everyone, not just those enrolled in CPC Plus. Yes, yes, yes. I have to emphasize that, and we are going to be doing a CPC Plus webinar, I think, next week as to what the requirements are. So anyone can use the CCM or TCM coding. And as I said, they made that adjustment this year for the FQHCs and RHCs to be able to bill for CCM because they were not allowed to do that. But everyone is allowed to bill for either of those two codes. It's not dependent on your payment mechanism as long as I said, as you get into new payment model, it may be that the payment model incorporates the use of chronic care management, but that's a separate issue. What you're asking is right now, today, can I bill for this? And the answer is yes. So I think that's, again, we'll be separating those two ideas as we go through the webinars over the next few months, and that is what's required for a new payment model versus what's required for, you know, just day-to-day practice if you decide to stay on a fee-for-service or anything else. Okay, another question coming up. Some hospitals are providing TCM. If physician offices want to provide TCM, who's the one that will get reimbursed? Who's ever providing the care? So, you know, this is something I'd say you want to make sure that if you are an employed physician, you understand what the model is for your healthcare system. Who is contacting that patient within 48 hours, which is the initial requirement to do TCM billing. You have to contact the patient within 48 hours to set up the ongoing care for 7 to 14 days out for the visit. If they're providing that, and a lot of places do, they have someone who does nothing but contacts that patient as the patient comes out of the hospital to make sure that that 48-hour requirement is met, and they schedule that patient for their follow-up visit. So if you are part of a system that's doing that, the actual visit is being done by the patient, or I'm sorry, by the practice, whether it's the physician or, as we said, the nurse practitioner who's doing that follow-up visit. They're the ones who get billed for it. Now, whether or not there's an arrangement to pay the person who's doing the call to schedule and is doing the call within 48 hours is what you're going to have to determine if you as a practice are not doing that call yourself. Is there someone who's getting paid for it from the hospital side? But as far as who's going to bill for a TCM code for the increased visit time, that is actually absolutely the practice who is doing it. So with that, I would say let's revisit everything as the rules become final. We can only hope that we'll have a better idea within the next 2 months of where CMS is running with these programs. But the reality is nothing's going to go away with chronic care management or transitional care management. It is being built into every single program, every single payment reform. So if you haven't set this, this type of review up, make sure that you be looking at it as to what the technical requirements are and talking to your practices about how you too can implement it. But if you have any questions, feel free to get in touch with either Scott or me, and we hope to see you on one of our next webinars. Take care and have a great day.